Close colleague of mine, an ER director in the Midwest, called me recently. He sounded absolutely defeated. It was about 3 in the morning his time, and he had just finished a shift that perfectly encapsulates the crisis we were in. He had a patient come in, and let's call him John. John is a farmer, tough as nails. He drove himself to the ER while having a cardiac event because he didn't want to wake his wife to call an ambulance. And that's the kind of resilience we see in rural America every day. My colleague is looking at John. He has monitors beeping. He has nurses moving fast. They're doing everything right clinically. But here's the problem. John had a full cardiac workup at a major city hospital just 2 weeks prior. He had the scans. He had the stress test. He had the data that would tell the ER team exactly what was blocked and how to fix it. But my colleague couldn't see it. Different hospital systems, different electronic medical records. The interoperability button was grayed out. He tried calling the other hospital, but at 3 a.m., no one in medical records answered. So there he was, standing in a trauma bay with millions of dollars of medical technology around him, holding an iPad that has more computing power than NASA used to go to the moon, and he was functionally blind. He had to treat John based on guesswork. He had to repeat tests that had already been paid for, and he had to waste time that John didn't have. He told me on the phone, he said, "Sarah, I have the best tools in the world, and I felt like I was practicing medicine in 1950. That story? That's not an exception. That's the standard of care in America in 2026. So we have more technology than ever. We have AI, genomics, robotics, and sensors, and yet life expectancy is stalling. Burnout is at an all-time high, and patients feel more lost than ever. Why? Because we're building walls instead of bridges. Welcome to the Borderless Healthcare Revolution. I'm Dr. Sarah Matt. This podcast is not about healthcare futurism. There are plenty of shows that'll tell you what medicine looks like in 2050. And honestly, I don't care about 2050. I care about next Tuesday. And I care about what happens when the shiny new technology breaks and there's a human being waiting for care. I'm a clinical realist. My background's a little different than your standard healthcare strategist. I'm a physician, yes, and I still work rural charity shifts, but I'm also an executive at Oracle. I've seen the billion-dollar tech deals and the massive cloud infrastructure projects. And before all of that, I was a firefighter. So I sit at the intersection of the P&L statement, the tech stack, and the trauma bay. And from where I sit, I see a massive disconnect. The people building the tech have often never touched a patient, and the people touching the patients are too burned out to learn the tech. So this year, 2026, is going to be the most critical year of the last decade of healthcare. We have the $50 billion CMS Rural Health Transformation Program, and we have a massive shakeout happening in the startup world, where the free money has dried up. So for this first episode, I want to lay out the manifesto. I want to give you the 3 pillars of the clinical realist approach. If you're a hospital leader, a founder, or just someone trying to navigate this broken system, this is your operating system for the year. So let's start with the money, because in healthcare, if you want to find the truth, you have to follow the money. And right now, everyone's talking about the new CMS Rural Health Transformation Program. $50 billion. It's the single biggest capital event of the year. And if you run a rural hospital, this looks like a lifeline. And if you run a health tech startup, it looks like a gold rush. I have founders emailing me every day asking, how do I get a piece of the $50 billion? And I tell them all the same thing. Danger. Because historically, when we dump cash into healthcare without a clear strategy for access, we don't actually get better care. We just get more expensive consultants. And we get what I call innovation theater. Innovation theater is what happens when a hospital buys a fleet of telemedicine carts to look modern, but they sit in a closet being used as coat racks because the Wi-Fi in the West Wing doesn't support video streaming. Innovation theater is when a startup raises a Series B on the promise of disrupting care, but their product adds 12 clicks to a nurse's workflow, so no one uses it. The market is shifting, and from 2020 to 2025, the market was all about growth at all costs. Raise money, deploy pilots, disrupt everything. But in 26, the market's about ROI and access. The hospitals are broke. They don't have money for experiments. They need tools that work. They need tools that keep the lights on. So if you're listening to this and you want to win this year, you have to stop selling innovation. Innovation is a luxury good. You need to start selling infrastructure. Infrastructure is what's happening when the power goes out. Infrastructure is resilience. And that brings me to the 3 pillars of the clinical realist philosophy. These are the themes we'll be exploring all year. Pillar number 1 is implementation over innovation. I say this all the time. Tech is useless if it fails on a Tuesday night in the ER. We have an obsession with the new. We want the generative AI agent. We want the drone delivery. But we haven't fixed the fax machine. Implementation means understanding the workflow. It means knowing that if your software requires a nurse to remember a second password, they're going to write it on a sticky note and put it on the monitor. And now you have a security breach. Not because they're lazy, but because they're busy saving lives. So the best technology in 2026 will be invisible. It'll run in the background. It won't ask for credit. It'll just work. So I talked to health tech founders who are suffering from a disease I call pilotitis. And this is the leading cause of death for startups right now. You get a pilot at a hospital, you celebrate, you think you've won. But 6 months later, the pilot ends and there's no contract. Why? Because you solved a clinical problem, but you create a financial problem. You didn't understand the billing codes. You didn't understand the implementation codes. So if you want to survive, you have to obsess about the boring stuff, the plumbing, the interoperability, the reliability. So don't think you're going to be the Uber of healthcare. Be the plumber of healthcare. Pillar number 2 is the human infrastructure. And this is the one that keeps me up at night. We talk about beds and machines and drugs. We talk about capacity as if it's just a math problem. But the actual infrastructure of healthcare is flesh and blood. It's the doctors, the nurses, the techs, the administrators. And right now, that infrastructure is crumbling. We treat providers like inexhaustible resources. We think, oh, just add another module to their training. Just add another click to their chart. Just ask them to stay another hour. You can't burn out your workforce and expect better outcomes. It's physically impossible. So in my previous life as a surgeon, as a firefighter, we had a very different approach to leadership. In the fire service, safety and team cohesion comes before the mission because without the team, there is no mission. If the firefighters go down, the house burns down. In medicine, we have a hero complex. We believe we should destroy ourselves to save the patient. And while that's noble, it's not a business strategy. It's a recipe for collapse. So resilience isn't a pizza party in the break room. It isn't a mandatory wellness module on a Saturday. Resilience is safe staffing. Resilience is reliable tools that don't crash. Resilience is leadership that understands the difference between a busy shift and a dangerous shift. So we need to bring the firefighter mindset into the C-suite. Assess, commit, execute, and protect the team. Pillar number 3 is geography is history. And this is the borderless concept in my book. Yes, I fight for rural health, but rural is just a proxy for the underserved. There are zip codes in Chicago and Los Angeles that are medical deserts, just like my town. The promise of technology was that it would kill distance, but we've let regulations, greed, and laziness keep distance alive. Why can I FaceTime my cousin in Australia for free with perfect video, but I can't get a specialist to look at a stroke victim in the rural ER without a $50,000 contract and a proprietary card? We have to break the geography model. Care should be determined by the patient's need, not their zip code. But borderless isn't just about maps. It's about silos. The most dangerous borders are the ones inside the hospital. The border between the ER and the ICU, the border between the payer and the provider, the border between the patient and their own data. We have to tear down these silos. If you're a hospital administrator, your job this year is not to buy more buildings, it's to integrate the ones you have. It's to make the data flow like water, not like molasses. So how do we actually do this? How do we move from innovation theater to clinical realism? So I pride myself on being scrappy, and I built my brand and career by doing a lot with a little. So I want to give you a challenge. I want to give you some homework for this week. So if you're a health tech founder listening to this, I want you to stop coding for one day. I want you to get out of your WeWork office and go to a hospital waiting room. Don't ask for a meeting with the CEO. Just sit in the waiting room for 4 hours. Don't talk. Just watch. Watch the intake coordinator. Watch how many times they have to answer the same question. Watch the frustration on the patient's faces when they're handed a clipboard with paper forms. Watch the friction. And then go back to your team and say, how are we reducing this friction? Or are we adding to it? So if you're building a tool that adds friction, even if it's brilliant, you're part of the problem. If you're building a tool that removes friction, even if it's boring, you're going to win. So if you're a hospital leader, I want you to find your firefighters. Find the people in your organization who actually put out the fires every day. The charge nurses, the unit clerks, the IT help desk guys. Ask them one question. What is the one thing in your day that is stupid? Not what's hard. Medicine's hard. Saving lives is hard. We signed up for the hard. But ask them, what is stupid? What implies a broken process? What implies a tool that doesn't work? And then have the courage to fix that one stupid thing, even if it costs money, even if it's annoying. That's how you build trust. That's how you reinforce your human infrastructure. So we have a massive year ahead of us. We're going to be tracking the $50 billion fund. We're going to be interviewing the clinical realists who are actually fixing things, not just talking about them on LinkedIn. So this message resonates with you. If you're tired of the hype and you want the reality, I invite you to subscribe. We're going to be here every month, maybe even every week. We'll see. And if you want the manual, if you want the blueprint for everything I just talked about, pick up my book, The Borderless Healthcare Revolution. But actually, here's a better idea. If you're a leader planning your fall conference, your animal strategy retreat, don't just buy the book. Bring me in to teach it. My team has set up a new model for 26. So when you book a keynote with me, you include several books for your team too, because I don't want to just give a speech and leave. I want to leave you with the tools to execute. I want your team to be reading the same playbook you are. So go to drsaramatt.com and let's get this on the calendar. I'm Dr. Saramatt. Stay scrappy, fix the pipes, and I'll see you next time.